I have been asked here to really give a bit of a perspective on healthcare reform and what it might mean to you. I do have an eclectic background. I'm currently the clinical chief at Yale, so I've returned to academics after about 25 years in practice. Started out in a small practice and helped put together what was then the largest practice in the country, Minnesota Gastro. So I've worked in all different spectrums of practice. I'm on the Alina Board of Health. That's a health system that's about a $3.4 billion health system in Minnesota. So it gives me a health system perspective, which is really quite interesting. But again, my heart and my soul really remains in community practice. So I'm going to first tell you, first of all, when I give this talk to people that are my age, 50 and above, everybody is depressed about what's happening in healthcare because there's this sense of loss. When I give it to people like you who are young and starting out, I see a lot of people thinking that this is an opportunity. And I really want to leave you with the idea that what is happening in healthcare is an opportunity to really do phenomenal things. We're not going to be paid on a strict fee-for-service, high-throughput colonoscopy, and believe me, after 20 years, high-throughput colonoscopy is like brain dead. It's really a chance to embrace remote monitoring, social media, interacting with patients in a different way. And for those of you who can really think through this and see this as an opportunity to build in whatever practice environment, whether it's clinical practice in community or academics, are really going to have a phenomenal career. There's no better time to be in gastroenterology. So forget the finances, forget economics, forget all that. You're going to have a great career. This is going to be an opportunity really of a lifetime that very few people get. So this is the traditional gastroenterology model, small practice. We added anesthesia, we added pathology, we interacted with our hospital through a fax machine, and that model is dying. It doesn't mean small practice is dying, it doesn't mean that independent practice is dying, but this model of being so autonomous is walking dead. It can't happen anymore, and I'll show you why. So here's the outline of the conversation. First of all, I'm going to go through healthcare economics. What are the implications for you? What do payers want? How is restructuring of healthcare actually happening? And then who's driving the change and how are we responding? So what do we know about the market? Well, first of all, these are the federal tax receipts and this is the federal spending. So you see this gap, that ain't good. That's our federal deficit, which is at a historic high, and what that means is that more and more money is diverted to interest payments. So that means all discretionary funding is incredibly limited. We also know that our healthcare costs continue to go up. The Affordable Care Act did nothing to mitigate cost. What it did is provide access to many more people, and I think that's a great thing, but we're still now facing how do we mitigate that cost trend. Over the last 10 years, healthcare costs and hospital expenditures have doubled. It's now 17% of the gross domestic product. It's going up to 19.6% by the year 2020. That is absolutely unsustainable. So that's the bad news. Commercial insurance rates are skyrocketing. It now costs on average $21,000 to insure a family of four. That's about 40% of the median income. Basically, anybody who's earning $75,000 to $80,000 and above is subsidizing those below, and that's a significant portion of the population. The Medicare math, on average, people pay in, a couple pays in $109K and takes out about $343,000, so that's obviously something that can't be sustained as well. So that's the bad news in the economics, and Bill Gates really put it best. He said politicians must address tough questions about limited resources. How many teachers are you willing to fire in order to have 78-year-olds have a procedure which will be invented 5 years from now that adds 4 months to their lives? May sound terrible, but those are exactly the choices that we're facing. So healthcare reform is accelerating. It's here to stay. There's no going back. The Affordable Care Act will not be repealed. In 2009 was first the Recovery Act. Second was the Affordable Care Act in 2010. And over the next 6 years, there will be about $250 billion stripped out of Medicare payments. And that's really only the beginning. So how do we do that? Well, here are the top trends that are going to impact your practice no matter where you practice. Performance measurement, consolidation really at all levels of healthcare, cost containment, much more accountability, and population management. Here's the secret. There are going to be winners and there are going to be losers. So be on the winning side. Let's understand Healthcare 101. There are basically 4 P's in healthcare. There's the patient, purchaser, provider, and payer. So the first step, the ultimate payer of all healthcare is someone who is earning money. You either pay in taxes to really subsidize those that are not working at your level, or you subsidize it through your benefits. So every income increase or salary increase over the last generation has been completely wiped out by the increase in healthcare benefit costs. There are only 3 purchasers of healthcare: state and federal government, businesses, and the individual insurance market. Those are the purchasers of healthcare. And health benefit companies, the payers, WellPoint, United, they're really only brokers that manage fund distribution. Some are for-profit, some are not-for-profit. Purchasers want increased value for their healthcare dollar. They want better quality and health outcomes. They absolutely want transparency, and that's something that you're going to have to live with. My generation did not. They also want predictability. On average, it's $70,000 in administrative cost per provider every year. So that obviously is going to have to change. And everybody wants to transfer risk. So the way you transfer risk to an individual is through copays and high deductibles, to health systems, through accountable care, total cost of care, bundled payments. Those are all financial risk models. And for providers, for the first time really in a long time, individual providers are now being forced to collect deductibles and continue services even if patients drop insurance. That means these high deductibles have to be collected by individual practices or places like Beth Israel. And so the amount of pro bono care, even with the Affordable Care Act, is really skyrocketing for 2 reasons. Number one, the increase in undocumented immigrants who cannot get insurance. And the second is the collection of these very, very high deductibles. So in the next 5 years, the Affordable Care Act will be implemented. Insurance marketplaces will force healthcare to become retail, and I'll explain that in the next slide. There are 5 types of patients that you're going to see. What are called the 3 M's, Medicaid, Marketplace, which are the exchanges, and Medicare, employer-based insurance, and self-pay. That's it. So those are all the sources of payment, who brokers all those monies. Fee-for-service will switch to what is called value-based reimbursement. Cost will be job number 1, probably through 10. And the structure of referrals is definitely going to change as more and more primary care providers are swept up into large healthcare systems, and I'll show that. So here are the 2 cheapest plans in Minnesota on the marketplace. These are what are called the bronze plans. And so it's really great. No charge after deductible, $250 a month. No charge after deductible for pharmacy. Look at that deductible. That is $15,000. That's the deductible. Out-of-pocket expenses that have to be met. And the next plan for $313, $20,000 deductible. That's why healthcare is becoming retail. And that's why you're going to be marketing your healthcare, whether you're in a place like this or in private practice. You're going to be marketing to a much more sophisticated audience, just like Expedia markets hotel rooms or travel or things like that. And anyone who thinks that physicians aren't going to be looked at like you shop for a hotel room on Hotels.com or Expedia, price first and then those 5 stars, that is absolutely coming to healthcare. So what's the industry response? Well, there's rapid consolidation really at all levels of healthcare. That's through 2012. These are hospital mergers. That's only part of 13. It's way up here by now. So there's consolidation there, and the world is changing. So we're going from traditional fee-to-service through these steps up to really taking on total cost of care, which is a form of capitation. In gastroenterology, the 2 things that are going to really affect you are moving towards bundled payment for procedures, and colonoscopy is certainly out front, and then also a multidisciplinary medical home. So building a medical home and doing a carve-out for IBD patients, for example, is already being implemented in multiple areas across the country. That means a tremendous amount of financial risk. It means you're going to have to coordinate care in ways that we as specialists are not necessarily used to. And you heard people this morning saying, I'm only doing consult and not primary care or not hospital admissions. That's okay, you can do that, But if you're in that model, you're going to be a continuing discounted fee-for-service model. If you're willing to put together a sophisticated medical home, you're going to be rewarded for that. This is the model of healthcare delivery both now and in the future, and this is rapidly evolving. It's certainly evolving here, and it's certainly evolving in major marketplaces. It's the rise of these integrated delivery networks, or IDNs. It is a combination of hospitals where they have seamless inpatient to outpatient transitions, and then the ancillaries of the hospitals. It's usually hospital funded and led. You have a strong primary care base. You have a specialty network that is either employed, that would be like a Kaiser model, or contracted, that would be an independent group that contracts as an affiliate. And then you have an ambulatory network, transitional care units, skilled nursing facilities, etc. This is all an integrated unit that will basically, this is like Partners, for example. I mean, that's the most obvious example here. They will contract together, and so we will be part of that. Now, I will show in a couple of slides, if the contracted model doesn't work to provide a good market option, then that will be essentially the end of independent GI care. So it's really important that we get this right. So IDNs are aggressively redesigning care, radical operational performance. They really have to reduce costs and improve operating margin. You basically have to assume that you have to make money on Medicare. And right now, virtually every hospital loses about 10% on every Medicare patient. So the amount of cost coming out of these integrated delivery networks is pretty significant. The decision makers are changing. This is where people talk about physician autonomy and CEOs. Well, basically the decisions are being made at health system levels. I have a 1 o'clock phone call, for example. Basically, it's a request for proposal to roll up all of the equipment throughout the Yale New Haven health system into a single contract that we're offering out to companies. So it's a completely different change of dynamics. A lot of physician coordination. Physicians are consolidating into larger groups, some very disruptively. Massachusetts happens to be an area where there's still a lot of small groups. That's going to rapidly change in the next few years. I'm going to skip a few slides here and show you some key components so we have time for questions. There are 3 types of integrated delivery networks. This is the Kaiser model where everybody is basically an employed provider. This is the affiliated model where you basically have a little bit wider network of providers. You have mostly primary care employed, but the affiliated specialists. This is a little bit more cumbersome model, so it tends to cost more. So the height of these bars are the actual total cost of premium care for a population. So the higher cost must be worthwhile because of better and demonstrated quality. And the problem is academic medical centers are the most costly, usually a 25% margin above these other integrated delivery networks. And for a long time that was subsidized by commercial insurers. That is now changing. And a recent poll, for example, said for people with high deductibles, 78% said they would not pay more to be treated at an academic medical center. So the cost pressure on academic medical centers to become more integrated, get a better payer mix, break down these silos is mounting. It's entirely possible in the next few years we're going to have a few top-tier referral centers that bundle prices for transplant, hips, complex cardiac surgery. That's already happening in, for example, Walmart has designated 6 places across the country where they'll send people for transplants and other high-risk procedures. So it's entirely possible we'll have a few of those, a number of regional centers, and then a few other large independent or integrated delivery networks, and very few remaining independent hospitals and practices. Here's what the Minneapolis market looks like, just to illustrate that. So we did have 4 large healthcare systems. This is a lineup where I sit on the board. Here's Minnesota Gastroenterology, which is the large independent practice that I was with. We have Fairview, we have Health Partners, and Park Nicollet. So Alina decided it needed to form an accountable care organization. It is now partnered with Blue Cross Blue Shield of Minnesota. We are their major providers. Fairview did the same. They have the University of Minnesota physicians. They partner with another insurance company to form an ACO. We try to bridge that gap. We gave about, or we had about 10 to 11% of our business with health partners in Park Nicollet. They consolidated last year into a single closed network, kind of like Kaiser, so we lost that business, and that is basically the Minnesota market over the last 5 years. An incredible transition. So when you go into a practice, the thought of that practice being the same over the next decade, it's not going to be. You don't know what it's going to be, but you really need practices that have a forward-thinking strategy. So, does independent GI practices have the muscle to survive? That's my son, by the way. Here's the pressure on small and large practices. Number one, revaluation of 106 endoscopy codes, about a 9 to 30% hit for uppers. We don't know about colonoscopy. We anticipate about the same. And then there's a penalty phase for all the incentive programs for CMS now. Markedly enhanced regulation, meaningful use, patient safety, intense scrutiny of the current business model. For example, anesthesia, the in-office pathology is at risk. There are a number of things that practices have really relied on. Electronic medical records are consolidating. Epic is now over 60% of the market of large healthcare systems. A health system with Epic will go into an area and basically say, if you want referrals within our network, you must come onto the Epic system. So a lot of these practices bought EMRs over the last several years. We got a great EMR, it's fine. Swept away as soon as the health system says you're either in or out with Epic. So if that's a large part of their market share, they really have no choice. There are 7 different incentive programs that require your attention. So as you're talking to practices, not so much in large health systems, but independent practices, if they're not aware of the federal incentive programs, then I would be cautious about their forward-looking strategy. There will be public reporting of you. Basically, anything you do with Medicare, the amount of money they pay you, your billing, your participation in MOC, everything will be on a public website. It already is for the most part, but it will be. So you have to understand that. And there'll be extensive research and aggregation of data that will occur by payers, third-party brokers, employers, and health systems, and this will be most likely used to tier people in terms of reimbursement. So just be aware of that. I'm not particularly scared of it. You got to live within the laws, but just be aware that what you do is going to be transparent. So when you go to a practice, ask them these questions. Can that practice survive a 10% cut in the work RVUs for the 3 major diagnostic codes? That's colonoscopy, colon with biopsy, and colon with polypectomy. On top of the upper endoscopy cuts, hitting Medicare by 15 and commercials by 16. If they don't have a strategy around that, or if they're doing 70% of their revenue coming in because of high throughput colonoscopy, then you better ask them what their plan B is. What if ASC rates trend down by inflation? These are going to be flat for the next 9 years by law right now, so that'll trend down by inflation. So if they own an ASC, they need to have a strategy. What if you're paid only on professional fees? So if you're an academic medical center, you're really going to be paid only on professional fees, and you're facing these kind of cuts. So you really have to be careful in terms of your negotiation. And again, what if the pathology takes away? And what if the primary colon cancer screening modality shifts away from colonoscopy? These are somewhat scary, but they're also opportunities. If practices have strategies in obesity or nutrition or other things like that, or are creating a medical home for IBD or Hep C, those are really forward-looking strategies. This is basically how a lot of current community practices look. They're either being sucked into a black hole or they're being swept over by a dust storm. And I think that's a little bit pessimistic. So their options are one of 4. Wait it out. So you do an expense reduction. Hold on until retirement. No more vacations. Cut down on CME. And really, what are the implications for women who do want to have a family? And how do you negotiate that in the face of these expense cuts? You can almost expect a shift in some markets to greater 50% of business in risk contracting. Or they go out of network. They refuse Medicare or Medicaid patients. It's a very short-term play. It will not work in the long run. So if you have a practice that says, well, we just don't see exchange patients, not sure I would go into that practice. Many are joining a healthcare system. In 2010, the line crossed, so more physician practices are owned by hospital systems than by physicians for the first time in the history of the country. So as you're looking at practices, you can pretty much bet that there's going to be pressure to join a healthcare system. Or they create a large mega single specialty practice and make that play. So how do you thrive in accountable care? You have got to be in a practice that demonstrates value. Increased quality, decreased cost per episode, that's got to be part of their strategy. Looking at an integrated program that has a sophisticated electronic medical record, centers of excellence, clinical service lines, and outcome measures. This has to be sort of an integrated strategy. So those are the kind of things that will survive and thrive in the next decade. What about IBD care? Well, this is the typical IBD. If a Crohn's patient comes in, you know about the SONIC trial, you do combination therapy. Well, basically at Minnesota Gastro, we had almost 9,000 IBD patients. So we began to build in clinical decision support tools, preventive care, lab monitoring, clinical status and active disease, patient engagement surveys, red flag alerts for specific issues, clinical algorithms, and then the after visit sending to an outcome registry. Basically, this is what we built in. That is what is called population management, and that's what's going to be necessary to really do a good carve-out for IBD, which is certainly in the works at that practice. The AGA has a number of tools. We have a recognition program. We published on colonoscopy bundles, a number of clinical decision support tools, practice guidelines. Just implementing practice guidelines in a standard way across your practice is going to be a very important thing. We're doing a lot of advocacy. Here are the three presidents of the societies meeting with Marilyn Tavener, who's the administrator of CMS. Did that a few weeks ago, so there's a tremendous advocacy to make this a more transparent and more fair revaluation process. In innovation, we're really partnering with the FDA, and so getting involved in the AGA, if you get involved in some of these areas, you really can understand and talk with some of the officials of the FDA, device registries. Every March we have this Center for GI Technology and Innovation, which is probably, everybody who attends says this is the best conference they've ever been to. It brings together venture capitalists, FDA, early phase device companies, and clinical experts in a really wonderful conference in March. It's always in San Francisco, since that's where most of the VC people are. But that's a great conference, and it will allow you to really interact and really see what it's like to be an industry or to be an innovator. Year-round education, I would point out a couple of things. Practice management, we partnered with the ASGE in August. We have a microbiome meeting every year, a wonderful meeting. It switches from Europe to the United States. The Clinical Congress in the winter, it's always in Miami now, and it's really terrific. It's got a Partners in Quality part that really highlights the incentive programs. We have a Women's Leadership Conference, which is a wonderful conference. Marcia Crows Korea is the chair of that. Then, of course, DDW, which will be in Washington in the spring. You know about DDCEP. The AGA Foundation, we provide about $1.4 million in grant support every year. We're boosting that to $2 million over the next several years in stable grant support. Then, of course, we have our journals. So here's my last slide. Basically, it's the 10 steps to becoming a value-based practice, and this is included in your syllabus. But this is where practices absolutely have to go to survive. They've got to get organized. Big is good. Strong, fair, knowledgeable governance. A culture of quality with committed leadership. A business and cost structure is no longer going to work on eat what you kill. It just will not work in the long run. It's really got to be built around cooperation and measurement. Internal process improvement. Got to be aware of all the regional, state, and federal initiatives. An HIT that will probably eventually go into a system, HIT. You've got to learn about population management, build capacity to assume risk, and total cost of care is going to be really the ultimate endpoint that a lot of you will be facing. So I will leave you with this. Every pessimist sees difficulty in every opportunity. An optimist sees opportunity in every difficulty. You're in an exciting time. It's going to be totally different than what it is now, but you're all going to do very, very well. So I wish you luck. And I'm really sorry to cut this short, but planes don't wait for me.